Then it's a pleasure for me to introduce my former boss when she was chairing the anesthesiology department at the National Cheng University in Taiwan, and I became the visiting professor there. Professor Tsai is one of the founders, I would say, of pain medicine in Taiwan. She has been 2 times the president of the Taiwan Pain Society. She was the president of the Anesthesiology Society, and I want to see now, she's also the WIP co-director of the Interventional Pain Workshop, where she really contributed with the registration of the FIP and SIT examination. And she has published more than 85 articles on anesthesia and pain management, including basic research in the field of opioid effects on immune systems and wound healing. She was also the editor of the book Clinical Anesthesia, Experiences and Evidences. Her main interest field in the is chronic, facial and spinal pain with the focus on interventional management and regenerative medicine. Professor Tsai, it's an honor to have you here, and we are delighted to listen to your lecture.
Thank you. Thank you, Robert, and Dr. Amar Sosi. As honorary secretary, it is an exciting moment indeed. WSPC is back again in this incredible and amazing city, Dubai. I feel very honored to be invited to Tsai for talk about the percutaneous intervention on Sphenopalatine and the Gasserian ganglion for orofacial pain. We have PowerPoint. For management of trigeminal neuralgia, medical therapy always the first line. If the fail in medical therapy, a lot of options we can choose. Yesterday, Dr. Sorti already mentioned about the peripheral nerve stimulation. And we also can choose transcutaneous or percutaneous, radiotherapy or open surgery. And here. But today, my focus will be on the Gasserian ganglion and the Sphenopalatine ganglion procedure, especially on the fluoroscopy guided procedure. I think many clinicians has many experience about this procedure. We know the Gasserian ganglion is in Merker's cave. There are 3 percutaneous Gasserian ganglion procedures commonly used. Radio frequency, heating current may selectively interrupt the nerve fiber. And the Gasserian injection use chemical damage nerve fiber in cistern. It is not selected, and the balloon compression, also mentioned by Dr. Sorti yesterday. All the procedure needs to pass through the foramen ovale. In this foramen, the mandibular nerve, accessory meningeal artery, and the lesser petrous nerve also are passed through this foramen. How how to play?
今天这个病人是左侧，
Can you shut down the
我
voice?
们竞争的地方呢是在
This video is made by made it in National Technical University many years ago. And we can see our needle through the pterygo mandibular space to the foramen ovale.
会感觉有一个阻力好像消失了，这个 mandible 拔下来。
If you take out the mandible, we can see the skull base.
foramen ovale 在这里，
Our target is here, foramen ovale.
可以哦。
And the direction, the trajectory
那我
is
们
like this
看
way.
从上面来
From
看
the
呢，
skull base, we can see if we pass through the foramen needle, it's mucus cave. The Gasserian ganglion is sit on here,
地方刚好就是
petrous bone of temporal bone,
所以我
petrous
们真的
portion
会
of
有
temporal
可
bone.
以转。这 ratio 没有掉吧？
The foramen is not bigger. It's about 7 millimeter length,
从上面
and
看就在这边了。
here we can see the mucus cave. Can you put the screen larger? To the full screen. We used to use the traditional landmark to put the needle in, but now we use the image guided. Can you put the screen into the full screen? Yeah, full screen. Oh no, just keep going. Yeah, we all usually we use the curved needle with a 0.5 millimeter active tip. The landmark is very easy, about 2 finger press lateral and to the epithelial midpoint below the pupil and to the direction of middle of zygomatic arch. I don't recommend the beginner to just one step to reach the foramen. Usually, step by step is safer. And when you pass through the foramen, you can feel the loss of resistance.
这个我有感觉。
And remember, my finger is already
没有照一下。
contaminated, so I changed the glove. Patient usually under propofol anesthesia, and then we take out the needle, and then we can see the sometimes the CSF outflow if the needle tip is in the system. And then we check the lateral view of the depth of needle. You can see the tip of the needle is just in the border of cleavers. And after confirmation of the needle tip, we wake up the patient. And you can see the CSF outflow. And we wake up patient to start a sensory and motor test. Usually we first use motor test and then sensory. If the patient identifies the needle position, it's just right the pen area, and then we can anesthesia again, infuse propofol and some fentanyl.
对吼，是不是你听呀？
We ask the patient if this is the pen area, and he say yes. This is the V2 area, that's the V2 area. So the needle tip is a little bit higher from the foramen ovale. And then we start to propofol infusion and radio frequency thermocoagulation. Use the traditional landmark, we still can get a very high successful rate to pass through the foramen. But now we have to get more successful rate, near 100%. So we use the submental and oblique view, the image guided to direction of the needle is parallel to the axis of the C-arm internal region. And with this, we can successfully nearly 100. We can see the foramen near a medial mandibular border and at the level of second molar. And you can see many kind of, sorry. Many kind of foramen shape and the size in various patients. Sometimes you cannot see very clearly. So the traditional landmark is sometimes useful. In the autopsy, we can see the shape of the foramen ovale. Not always the oval shape. Sometimes bony variation with spine or trabecle or lamina. And the trajectory of the needle is about 1.5 centimeter posterior to the dorsal cellar, with depth not exceed the cleavage line. And these two patients V3, so the needle tip is in just over the foramen ovale. And we can see the Gasserian ganglion is formed by the fusion of the series of cell body. The ophthalmic division located dorsally, and V3 is ventrally. And there is many vessels and nerve around the ganglion. From courtesy of Robert von Steventer, we can see the ganglion by endoscope. We can see the ganglion actually is a mix of many nerve fiber together. It's not like I always think, like a solid. It's like a web, spider webs. So if we use thermal coagulation, we have to identify the precise lesion area. This is from 7-star scope. It's very precious and unique video, I think. Test stimulation is required to properly position the needle tip. The patient should be able to respond to the question, and then we can perform the neuroablation. I usually use 70 Celsius for 60 seconds and 2 times. And here we can see the report from Professor Erling. They collect more than 3,000 new patients. And the successful rate, immediate pain relief is 96%. And the pain recurrent in first year is about 14. And in 5 years is about 30%. And no mortality. And the side effect is at this list is not very severe. And we can also use cholesterol rhizotomy. The chemical damage in nerve fiber is system. Merker's cave is denoted with omnibag. Free flow of CSF is obtained, and administered 0.3 milliliter glycerol is necessary. And patient is kept in sitting position with neck flexed for 2 to 3 hours post-operatively. And the balloon compression rhizotomy, yesterday Dr. Sortin mentioned, so I skipped this. Compare with these three procedures, the outcome profile for initial pain relief in a single center 70 years follow-up, you can see the balloon compression as the best result. And the thermal coagulation, the glycerol rhizotomy is about similar. And for the long-term pain relief, we can see balloon compression is seen have a better long-term outcome still. And the other two procedures is about similar. For the rate of numbness, we can see balloon compression is increase the rate in severe numbness compared with other two procedures. And the complication rate, we also can see the overall complication rate of balloon compression is higher than the other two. So, it depends on patient. We choose these two procedures. For the balloon, if the patient is V1 and all 3 branches, we can choose a balloon. For patients that are not cooperative, or we can choose a balloon. But for patients especially indicated for V2 or V3 or V2 and 3, we choose radio frequency thermal coagulation. But patients need cooperative. Is PulseIF effective for trigeminal neuralgia? According to the study from Professor Erding, they use 2 bursts per second of 30 milliseconds for 2 minutes. The conclusion is not effective. However, the Dr. Fan, they published in 2015, they use high voltage PulseIF. The conclusion is PulseIF is an effective and a safe interventional therapy choice for trigeminal neuralgia. So, we can summarize for the percutaneous intervention on Gasserian ganglion procedure. Treatment should be individualized, and desensitization may occur with all ablative procedures. Outcome of treatment worse with chronicity. The procedure can be repeated if pain recurs. An increase of pulse output voltage and the electric field intensity is effective and safe. And now I will talk about a Sphenopalatine ganglion procedure. We know that topographically, Sphenopalatine ganglion is related with mesentery nerve, but functionally, it is connected with facial nerve. Here we can see the nucleus for the ganglion is in the superior subantennary nucleus, and the ganglion here is snapped for the parasympathetic nerve system, but not for sympathetic or other nerve fiber. The role of the SPZ in chronic headache may be because the parasympathetic fiber provides secretory function to the lacrimal nasal palatine and the pharyngeal glands, and also some parasympathetic branches travel through the orbital cavity and innervate the meningeal or cerebral blood vessel, which play a role in the pathogenetic or migraine. Also talked yesterday by Dr. Sordi. So the trigeminal autonomic reflex maybe play a role in the treatment for the SPZ ganglion block, especially for the cluster headache and other kind of neuralgia, like a shoulder or persistent idiopathic facial pain or migraine possible. This is cluster headache. We can see the patient tearing and and had nasal congestion, rhinorrhea, sweating, and the watery eye, and the headache around this area, frontal and periorbital area. Usually is male. And where the SPZ? It lies in the Pterygopalatine fossa. If we take out the zygomatic arch, we can see the Pterygopalatine fossa is about 2 centimeters and 1 centimeter between the mesentery sinus and the pterygoid plate. So, for the image guide, we usually put a metal line for the fossa, and the entry point is just below the zygomatic arch. Here you can see the needle is in the fossa, and in the IP view, we can see the needle tip is just lateral to the nasal septum. This is another case. It's not a very difficult procedure. And after confirmation of the image, we sensory stimulation to get the right position for the needle tip, and then we start radio frequency lesion. Yeah, the complication is not very severe. Usually we don't lesion too much because to avoid the dryness of the eyes. But sometimes the patient feels the numbness in palate, but generally disappeared after several weeks. We can see the report from 2019 from Dr. Lopez. There are 37 patients, and they get 5 patients complete relief of pain, and about 56% had a partial and transient relief, and about 30% not improved. no significant superiority of RF over pulse RF. But in my opinion, I think our radio frequency is more effective than pulse RF. Our experience for the preliminary report is we have 15 patients, and we got 7 patients that has complete relief of pain for 1 year, and 7 patients has partial relief, and 1 person not improved. And I use pulse RF with RF together on the Sphenopalatine ganglion. And no complication associated with the technique. Thank you, that's my talk.
Thank you very much, Professor Tsai, for this beautiful and instructive presentation. Maybe someone in the audience like to ask a question to Professor Tsai.
Thank you very much for the presentation. I am Yasser from Qatar for the help.
Can you stand up, please?
Yes.
Sorry.
First question, in which criteria you choose between